So, okay. So good afternoon, everyone, and welcome to our seminars in ageing for today. So my name is Tracy Comans. I'm the director of the National Ageing Research Institute. I'd like to begin by acknowledging the traditional owners on the land in which each of us are meeting today. For me and the people at the offices of NARI, that's the Wurundjeri-Wurrung people. And I'd like to also acknowledge the traditional owners of lands and waters across Australia and pay my respects to elders past and present and to all Aboriginal and Torres Strait Islander peoples. First, a bit of housekeeping regarding our seminar today. At the conclusion of our talk, we'll have some time for Q&A. So if you have any questions along the way, please submit them using the Q&A function. You'll find that it looks like two bubbles about at the top centre of your screen with a Q&A. One of them has a question mark. The chat function's turned off, so please use that Q&A. You're muted and the camera's turned off by default. If you prefer during the Q&A session, use the raise your hand function and I'll be moderating that session at the end. So just a reminder that we'll be recording today's session and it will be uploaded to the website. So keep this in mind if you turn on your audio and video to ask a question. So today I'm very excited to be hearing from two colleagues of mine, Professor Ruth Hubbard and Dr. Natasha Reid from the University of Queensland. So Professor Ruth Hubbard holds dual clinical and research leadership roles as Director and Geriatric Medicine Consultant Geriatrician at the Princess Alexandra Hospital and Masonic Chair of Geriatric Medicine at the University of Queensland. Ruth is the founder and director of the Australian Frailty Network and is also one of the world's leading experts in frailty research academically. Dr. Natasha Reid is a behavioural scientist and senior research fellow at the Australian Frailty Network and Centre for Health Services Research at the University of Queensland. And Natasha works across epidemiological intervention and dissemination projects, identifying and addressing frailty in a number of settings. So today, Ruth and Natasha are presenting frailty in primary care. So welcome and over to you.
Thank you so much. Thank you, Tracy, and everybody at the NARI team for the opportunity to speak to you today. Our presentation is about 40 minutes long, which will leave plenty of time for questions and interactions and comments at the end. So next slide, Tash, please. So I would also like to acknowledge the traditional owners of the lands. In Brisbane, we're on the land of the Yagara and Turrbal people. I recognise the valuable contributions of First Nations communities to Australian and global society. Next slide. So we have a packed agenda for you today. We're going to tell you a little bit about frailty, about the background of frailty and frailty measurement in primary care, and then focus mainly on interventions. So they span the range of exercise, nutrition, medication optimization, and social engagement. And so Tash will be taking you through those agenda items, and then I will talk about how we have been developing some consensus statements for the management of frailty in community dwellers. And then I'll tell you a little bit more about the Australian Frailty Network. But over to Tash for the first kind of 30 minutes of the presentation.
Thanks, Ruth. And I'll just start by saying that I have a terrible post-viral cough, so please excuse me if I take some water breaks throughout the presentation. So just starting with the definition of frailty. So it's defined as a state of increased vulnerability to stressors and is indicative of reduced system redundancy. So essentially, it's more difficult for people who are experiencing frailty to bounce back from stressors. And it arises from multi-system deterioration. And a person living with frailty has reduced physiological reserve, and resulting in that reduced ability to maintain their homeostasis when faced with any sort of stressor. Living with frailty puts you at increased risk of geriatric syndromes, disability, institutionalisation in a residential aged care facility, and also mortality. And the figure that you can see on your right-hand side there is something that we talk about very often when we're describing the experience of a frail elderly person. So if you are quite independent, hopefully you can see my cursor, in your functional abilities, you sort of have this high level of function to begin with. You might be faced with a mild illness, such as a urinary tract infection or a cold, like I have, and you'll have a slight decrease in your functional ability. You'll bounce back pretty quickly to your original level of function. But if you are just sort of above this dependence-independence line, your experience of that mild illness might be quite a lot more pronounced than a person who is very robust. The recovery time will be longer and you may not bounce back to your original level of function. So it really describes this increased vulnerability to different illnesses. There's been quite a number of studies around frailty prevalence in the general population, and we do find different prevalence rates depending on what you're looking at. So in 2021, there was a review published looking at data across 62 countries, 240 studies and representing more than 1.5 million people. And using a physical frailty model, which I'll describe shortly, they found that the prevalence of frailty was around 12%. But using a deficit model, which is considers more domains, the prevalence was around 24%. And it was more prevalent in females. Also looking at frailty prevalence across age groups, as you would imagine, it increases with age. But still, around 5% of community dwellers aged 18 to 34 were found to be living with frailty in this particular study. So in the Australian context, by 2027, it's anticipated that more than 2.2 million people will be pre-frail, so this sort of vulnerable stage before frailty, whereas more than 600,000 will actually be frail in themselves. And frailty is associated with several individual complications like functional decline, falls and comorbidities, hospitalisation and mortality. It places a significant burden on caregivers, but also the healthcare system. So some studies have found the costs can range up to sort of 32,000 per year for people living with frailty. And early identification is really important, and we can focus on community dwelling older adults and an early management approach. So the reason to identify and address frailty in primary care is because early intervention works. It enables early detection, provides personalised care with targeted interventions. It can be used for, or it has predictive validity and can be used for planning and resource allocation across settings. In terms of measurement, the operationalization and measurement of frailty is probably one of our biggest challenges in the field, in that there are so many different ways that people have measured this construct. So in surgical patients across 110 different studies, there were 37 different tools identified. In older hospital inpatients, they found 48 different instruments, but out of these more than 600 papers, around 2/3 didn't actually use any instrument to measure frailty at all. And finally, in an overall setting, so combining any different population or setting, a review in 2016 identified 67 different frailty measurement instruments. And using this data, a review in 2018 found such wide variation in agreement between these measures, from no to almost completely perfect agreement. So I won't obviously have time to go into 67 different measures, but this is an overview of some of the most common ones. And it shows you the different kinds of domains that they cover. And interestingly, not that many actually include age as one of their criteria. So frailty can be independent of age, even though it does tend to increase as we get older. In terms of the most common measurement types in primary care, I have just a few to describe for you. The first one is the Reid phenotype, and it's one of the most well-known and widely used measures, particularly in research and clinical settings. This was developed by Linda Reid back in 2001, or at least first published in 2001. And it considers 5 different sort of physical criteria to identify people who are living with frailty. This is unintentional weight loss of 10 pounds or more in the past year, self-reported exhaustion, weak grip strength, slow walking speed, and low physical activity. So people who don't have any of these, so they have a score of 0, they would be classed as robust. If you sort of trigger 1 or 2 of these, you are often categorized as pre-frail, and 3 or more, you would be categorized as frail. The second measure is the frail scale, which is very similar. This one was developed by John Morley, also in the early 2000s, and it's often used in primary care settings. And I've seen it described in a lot of primary health network resources, such as from the Gold Coast PHN and also the Northern Sydney PHN. And again, it has 5 items to it. The first is fatigue. So asking how much time during the past 4 weeks have you felt tired, with responses ranging from all of the time to most of the time, scoring a 1. It also looks at resistance, so difficulty walking up 10 steps, ambulation, difficulty walking several hundred yards, illnesses, scoring a total out of 11. And again, loss of weight, so a decline of 5% or greater in the past 12 months, sorry. And the categorization for this one is the same as for the Reid scale. So 0, you're robust, 1 to 2, pre-frail, and 3 or more, you are frail. This is the clinical frailty scale. It was developed by Ken Rockwood, and it's used in many emergency departments in hospitals, particularly across the UK and Australia. It's sort of a much quicker clinician-driven assessment where people are categorized into these groups, and you can see the presentation of each of those there. And even though it's quite a simple and quick measure, it does correlate well to particular outcomes. So the top graph here shows the probability of survival. So if you score a 6 or a 7, your probability is very low over time, whereas someone who's scoring a 1 to 3, meaning they are either very fit, well, or managing well, their probability of survival is quite a lot higher. The second graph here shows the probability of avoiding institutional care. Across, just 1 moment. Okay, there we go. And the last one I wanted to talk about was this model of deficit accumulation. So that was developed by Ken Rockwood, and Rockwood and Minitsky. Hopefully I've said that correctly. Also in the early 2000s, and it conceptualizes frailty as a state of multidimensional risk. It can be measured by the quantity rather than the nature of the health problems. And the idea is that various disorders are accumulated by individuals during their lives, and the more deficits that are accumulated, the more likely that person is to be frail or living with frailty. Deficits can be symptoms, signs, diseases, disabilities, or even abnormal laboratory measurements, as long as they meet certain criteria. So they need to accumulate with age, be associated with adverse outcomes, to not saturate for all older adults. They need to cross different domains, so not just in the physical domain, but also in cognition and sensorium, for example. And if compared over time, they need to use the exact same items in longitudinal data. And finally, they need to have at least 30 plus variables. So this is what's called a Frailty index. And the way it's calculated is you take the number of deficits that a person has accumulated, and you divide that by the number of deficits that were measured for that person to derive a score between 0 and 1. Frailty indices can be constructed from different numbers and types of variables. So you could be using different large population data sets, for example, but that score between 0 and 1 can be compared across different data sets. So in a very large analysis looking at more than 36,000 people, they found that Frailty index values were closely comparable across countries, and they increase with age at approximately 3% per year in community dwellers and correlate highly with mortality. And the risk of adverse outcomes can be defined more precisely by deficit indices than by phenotypic models of frailty. One of the greatest or original criticisms of the Frailty index was that it took a long time to administer in sort of clinical settings. And that's because originally it was derived from things like comprehensive geriatric assessments. In the last, several years, there's been other versions or short forms that have come out, including from our group, and particularly Ruth and Ken, where these can be completed in 10 to 15 minutes. So much more feasible in a clinical setting or a primary care setting. And our team is also working on a number of electronic or digital frailty indices across Queensland Health, New South Wales Health, and also in general practice data. So moving on to interventions. Frailty has certainly gained a lot of recognition in the Australian policy context. So it forms part of the Primary Healthcare 10-year plan. It's discussed with CODA Australia in their policy documents, and it also was made mention of in the aged care reforms. And that certainly aligns with the publication of frailty interventions in the literature. And it is a topic of great interest, particularly because 45% of recent or randomized controlled trials in this setting have occurred or been published in the last few years. And there's also been 6 systematic reviews and or meta-analyses that I've been able to find looking at the impact of interventions on frailty or its determinants. So one of the most recent systematic reviews was published in 2023, and it looked at 69 unique randomized control trials. And the overall consensus from this systematic review and network meta-analysis was that physical activity, multi-component interventions, and nutrition interventions are associated with reduced frailty compared to a control group. And physical activity was the most effective type of intervention across all of these. Apologies. When it comes to health behaviours, there are many health behaviours that can influence the trajectory of health and development of frailty over time, a lot of which I've listed here. Within our team, we've focused on these 4 for the moment as sort of these core pillars of frailty prevention or management. So they include movement, or physical activity, nutrition, medications, and social engagement. This is a figure we've developed around how each of these pillars works independently, but also together to slow the progression of frailty. And we have a number of different projects that look at combining these into an intervention. So in terms of the evidence, exercise, like I mentioned before, has the most evidence around its impact or ability to prevent or improve frailty status. And there was a recent global consensus on optimal exercise recommendations for enhancing healthy longevity in older adults. And one of the sort of outcomes from that was they concluded that the evidence, which is summarised in the figure on the right-hand side, for the benefit of exercise on chronic disease, quality of life, frailty, muscle health, mental health, and almost every other condition without side effects is so compelling that it is unethical for healthcare professionals to not prescribe it to older adults. And I thought that was incredibly powerful in the way that they've described that. The Asia-Pacific Clinical Practice Guidelines for the Management of Frailty also talk a lot about exercise in its use for prevention and management. And some of the things that they list are that exercise programs should contain targeted programs to address muscle wastage and mobility loss. And that progressive resistance training should be used to enhance strength and power, reduce disability and fatigue, and lower the likelihood of admission to hospital or aged care. Of course, aerobic balance and flexibility training are still important, but they do mention that community-based programs often fall short of these recommendations in that they don't always emphasize the need for resistance training. And of course, adherence is always a challenge and tends to be low, particularly over a long period of time. So just going back to that global consensus statements on optimal exercise recommendations, they talk about resistance training at a frequency of 2 to 3 days per week, aerobic exercise training 3 to 7 days per week, and balance training 1 to 7 days per week, which is probably more related to people who are at risk of falls or have balance issues. In terms of nutrition, we obviously have the Australian Healthy Eater Guidelines. The Asia Pacific Clinical Practice Guidelines also talk about nutrition with an emphasis on protein intake, vitamin D supplementation when necessary, and addressing any malnutrition issues for people who have frailty or are living with frailty. And then the Mediterranean diet is one of the diets, I guess, specific diets that also has a lot of evidence for the prevention of frailty in community dwellers. So I'm not a dietitian, so I guess I'll just caveat everything I say with that. But what we tend to talk about is to focus on protein, fibre, and maintaining colour in dietary plans. So protein is essential for maintaining muscle strength, and colourful food is associated with increased phytonutrients, and that comes from a large component of vegetables and fruit. And a study called Eat the Rainbow found that people who have a very colourful diet have 42% better health outcomes related to weight, lipid profile, inflammation, cardiovascular disease, mortality, type 2 diabetes, and cancer. And then following on the principles of a Mediterranean lifestyle, mealtimes are meant to be social, and that sort of approach has been linked to a 56% reduction in frailty following the Mediterranean lifestyle. This is a great picture from it's a Canadian dietetics group that shows just thinking about a plate in terms of nutrition. And there is a very easy to do quiz that's been used in research settings that can be found at that link there. In terms of medications, there is a bidirectional association between polypharmacy, so a person taking a lot of medications, and frailty. So I've just put in there a systematic review and meta-analysis looking at 37 different studies. So it found that the odds of polypharmacy were higher in people who are frail, but that the opposite was also true. So the odds of developing frailty was higher in people who had lots of polypharmacy. So reductions in potentially inappropriate medications tend to be most effective, and this can be measured by the drug burden index measure, which I can discuss as well if you talk to me about that later on. And finally, when it comes to social engagement, I've just put in another study in there. There's not a review on this as far as I'm aware, but this study, looking at almost 10,000 people over 13 years, found that there is an independent association between both loneliness and social isolation with frailty. So social support interventions can not only reduce loneliness, but they can also help support other health behaviours that have a sort of cumulative effect on prevention in the community settings. In terms of resources that are available, I've just listed a few here. So for exercise, in Queensland, we have UQ Healthy Living, for example. So that's a multidisciplinary gym and environment for people over 50. There's also a number of private practicing gyms across the country, I'm sure. So Avanti is one that has gyms in here, New South Wales and Victoria, as that I'm aware of. We also have some PHN funded programs that focus on exercise interventions, and I think PHNs across Australia have commissioned a few of these programs. So this is two that are done by the Gold Coast PHN. And then there's also a government-funded program called Keep Able. So they do presentations, but they also have resources and tools that can be provided to both allied health professionals, but also to consumers. In terms of nutrition, there's Nutrition Australia that provides lots of different resources. This is another guide from a PHN. And there's also this evidence-based guide for identification and nutritional management of malnutrition and frailty in the Australian and New Zealand community. When it comes to medicines reviews, I'm sure there are many different pathways available, but there is the government-funded pharmacist medication review, where people can be referred by their GP to see a pharmacist to review medications. And while the pharmacist is free, there might be a cost of the GP for that particular person. And finally, for social engagement, this, I guess, uses a social prescribing model where people can be linked with free or low-cost resources in their local area that can support social engagement. So this is in Brisbane City. There's the 50+ Centre. There's University of the Third Age, which is, I've just listed the Brisbane one there, but they have them all over the country. And finally, there's another government-funded organisation called Live Up that provides a map of different community opportunities for older adults. There's also link workers and navigators that are free to access for consumers, and they can talk to them on the phone and help them find things that they might like to engage with. So in terms of challenges and opportunities in this setting, I think one of the biggest challenges that I can see is that there's a lot of duplication between government programs, PHNs, local councils, and the things that we all do in research. There's lots of different programs available, and that can be a good thing, but it can also sometimes confuse consumers. We do have to work within a fragmented care system. the need to, I guess, increase multidisciplinary practice is there. People need more training on frailty and its prevention or management. There's limited time in primary care settings for people to see their GP or a nurse. And there's obviously a resistance to the frailty label from community individuals. But there's also lots of opportunities. So we can do early intervention and prevention. There are more policy frameworks coming out that support ageing, including the new Aged Care Act. We can empower older adults and families to improve their self-management. It can also reduce healthcare costs if we do this. And there's upskilling resources already in place and underway, particularly with further work that is being done at the Australian Frailty Network. And just another mention of the new Aged Care Act, which I think really emphasises the need for re-ablement as well. So my voice has lasted, thank God, but that's all from me, and I can pass over to Professor Hubbard.
Thank you very much, Tash. So I just have a few minutes to talk you through how we have developed some consensus statements for the management of frailty in community dwellers. Next slide, please. So we were commissioned to do this piece of work by the Reform Office from the Queensland Health. So they wanted to have a set of principles and guidelines regarding the prevention and management of frailty in community dwellers. Because current guidelines don't offer that integrated multimodal approach to frailty management. So we set about developing guidelines across these pillars of health promotion and screening and addressing nutrition, exercise and social prescribing across the spectrum of frailty, from mild patients who are robust or with mild frailty through moderate and severe frailty. Then to address the optimization of medication, and the management of severe frailty we felt needed its own set of statements. Next slide, please. So, as I say, this was a piece of work we undertook in a consultation with the Queensland Health Reform Office, and we convened a group of 77 experts across every Australian state and territory. And one of the key principles of the Australian Frailty Network is that we engage consumers. And so we undertook this process alongside 6 consumers who were involved from the very outset. As soon as we had this commission, we engaged the consumers, and they were integrated into each of these 6 working groups. And we also liaised with endorsing organisations to approve the processes and to review the statements once they were developed. Next slide, please. So this was our aim, to develop national consensus statements on the prevention and management of frailty among older adults living in the community. Next slide. So the first step in the development of these statements was to establish the scope of this piece of work. So we realised very early on that we were not developing clinical practice guidelines, which requires a huge piece of work reviewing the literature and evaluating the evidence in relation to each of the statements that would be generated. So instead, our remit was to develop guidelines, or rather consensus statements based on expert opinion and a briefer review of the literature. So we had our first stakeholder committee, and from that we undertook a kind of snowballing exercise to encourage anybody who identified themselves as having an interest in this area, or thought that they were an expert or had something to contribute, to develop these consensus statements. So as I say, consumers were involved from the outset, and it was a modified Delphi process. Next slide, please. So for round one of the survey, there were 40 statements that had been generated by the 6 different working groups, and they were put forward to the 77 participants, including the 6 consumers, and our response rate was very high. There were 7 statements that were rejected outright that didn't reach any sort of agreement. And then the statements that had the highest level of agreement were presented again in a second round survey. Again, we had a good response rate of over 90%, and some of the statements were revised, but the rest were taken forward. So we have 19 statements now across the 6 different domains. Next slide, please. So I won't read all of these, but just to summarize that we had reached a high level of agreement for the 19 statements, and they span health promotion and screening. Next slide, please. Nutrition across mild, moderate and severe frailty. Next slide, please. Exercise. Next slide. Social prescribing and optimization of medication. And then the management of severe frailty focused on the individualization of care, the importance of engaging carers, and the vulnerability that older people living with frailty have at care transitions, so particularly from hospital to nursing home or hospital to home. Next slide, please. So the strengths of these consensus statements are that we feel that they represent the integration of care and the different perspectives of care that really should be instituted for older people who are becoming frail, and that we have considered the fact that frailty is not a dichotomous variable. People are not either fit or frail, that it is a spectrum of health, and our consensus methods were relatively robust, and we involved consumers throughout. The limitations are that the grades of evidence are weak in parts for some of these statements, that we did not have the capacity to focus on priority populations such as First Nations communities or cold groups, and we had limited representation from rural and remote Australia. The other criticism that we are trying to head off is that we haven't thought about implementation here. So in terms of how these things will be done, we wanted to start with statements about what should be done. So that's what we will be focusing on for the publication of these consensus statements. Next slide. So we are hoping that the statements will help with practice and policy, and to underpin future research. We will be putting some time and effort now into the generation of infographics and presenting these consensus statements in a lay-friendly language. Next slide, please. So I just have a couple of slides now about the Australian Frailty Network, because many people on the call won't have heard about us. So our mission is to transform how Australians age by creating and sharing evidence and supporting training of health professionals and early to mid-career researchers. So we have established our vision and our 5 statements of purpose and our core values which underpin our work. Next slide, please. And we started this was a grant that we were awarded from the MRFF in 2022. So we've grown now to involve a team of academic staff and higher degree research students. And we have a well-articulated governance structure with an embedded consumer advisory board. Next slide, please. So we are working extensively with national collaborators and international collaborators on several research grants. And the work with the Reform Office was the first time that we've had a commission to really think about the practicalities and the pragmatics of frailty and its implications at policy level. Next slide, please. So we have multiple sort of partners and funders. And next slide, the thing I wanted you to be particularly aware of is that we have established a Frailty Nexus, which is a community of practice for researchers and healthcare professionals with an interest in frailty. And this is something that's free to join. We offer monthly webinars which discuss different aspects of frailty research and frailty practice. So several people on the call have contributed to those webinars, and I thank you for your engagement with this activity. The Frailty Nexus has a membership of nearly 700 people now, so we are reaching out nationally to people with an interest in pursuing improving the lives of people with frailty. That's our mission at the end of the day. I think that was my last slide. So we have the opportunity for questions, which I think Tracy will be chairing. Thank you.
Fantastic. Yeah, thank you very much, Ruth and Tash. And I was thinking I'm just going to open because I've got the floor. Because Tash, I was really interested with all the different information out there. I think it does get really confusing. And then you did bring up the slide about that's a real issue. And I was wondering what you think about, you know, there's these clubs that are happening now in Melbourne. We have these St. Haven clubs. They cost about $50,000 a year. But you basically go in, you can get your medical care, you go straight into the dietitian, the exercise phys, you have your personalised program. All these things are covered basically in one spot. So this is fantastic if you're wealthy and you can afford the membership fees. For everyone else, it's kind of like you've presented a lot of information, a lot of different sources, and other people have even put up on the chat different other, you know, information that's out there. How do we help people assimilate this all? This is, I think, a real problem that we have. The information's there, we know what to do, but how do we, you know, how do we present it in a way that's perhaps similar to these clubs in coordinating without having the $50,000 a year membership fee?
I think that's the $1 million question, isn't it? It is difficult because there's so many different opportunities out there, and it, you know, we're talking about people's health literacy as well, and in addition to having lots of options, there's lots of people who won't know that they should be looking at things like this. So to be completely honest, I'm not sure. I think we're wanting to do mapping exercises to understand the full breadth of what's going on across Australia. And there are, I think, social prescribing programs that probably provide that link worker that would help individuals navigate what to do. But we don't necessarily do a lot of frailty training in that space. I'll hand over to Ruth. I'm sure she can do a much better contextualization.
No, I just think, so you can stop sharing your slides, Tash. I was just going to say that I think frailty is an example of intersectional inequalities, and we know that it arises often due to a life course of disadvantage, so low levels of education during childhood, poverty, social deprivation, all contributes to frailty development in old age, chronic disease. So the people accessing the 50,000 a year clubs in Melbourne are probably the least likely to need those sort of interventions. And so I think there is a public health imperative to reach out and help the people who don't enjoy the privilege of a healthy old age. And that's why we have pinned our vision and our statements of purpose very much around the fact that the frailty narrative rather than the healthy aging narrative, because these are the people that we should be reaching out to and empowering and helping.
Right. Leonie's posed a question. I don't know if you want to unmute Leonie, but just saying it's been really frustrating in terms of pilot programs starting and then stopping, for example, the Sunbeam program. Was it anything else you wanted to say about that, Leonie, in terms of, I mean, these are constant frustrations, I think, especially in terms of programs popping up that have been done before, again, with that coordination thing. Christy has asked, is there a plan to further cross-check these consensus statements, Ruth, with the literature, with the hopes of developing a practice guideline in future?
Yeah, so if I could get a huge grant from MRFF, I would certainly go ahead with clinical practice guidelines. That is the goal. But I think the consensus statements are a start, and there's been a lot of interest in those. And that was our remit from the Reform Office, to do a quick kind of review of what we should be doing. And yeah, it's definitely a foundation for future work. I was just looking at some of the other questions on the chat. Somebody's asked about depression and anxiety, which is a hugely important area in relation to frailty. So again, that bi-directional relationship, the fact that people who have depression during middle age often become more physically frail when they're older, and people who are frail are more likely to experience mood disorders. One of the researchers in my team, his program is based on looking at the relationship between frailty and dementia. That's something that interests us at the moment, because we feel that frailty reduces your threshold for the presentation of dementia. So the phenotypic diagnosis of dementia, the pathophysiology around dementia isn't as simple as plaques and tangles, because we know that there is not a direct relationship between your sort of pathological findings post-mortem in relation to the amount of plaques and tangles that you have and how you presented during your lifetime. And we think that frailty is the key mediator there, that people who are more frail during their lives are more likely to have dementia due to a low level of plaques and tangles. So if we can start focusing on delaying or preventing frailty during the life course, that would have a huge impact on the dementia prevalence.
Yeah, and I think there's increasing evidence, isn't there, around fitness and the protective factor that has. And I guess that sort of speaks a little bit to Alice's question, which is around evidence for reversal of frailty scores as a result of interventions. So what evidence have we got now that we can actually reverse frailty?
So there's reasonable evidence that frailty can be reduced. I'm a little bit skeptical about the reverse argument, except when I'm writing grants, when I say that we have the potential to do that, because that depends on the measurement of frailty. So if you're defining frailty in terms of muscle weakness and weight loss, and you put in a program that will strengthen your muscles and improve your weight, then you could argue that you have reversed frailty, but you've in fact addressed a couple of the frailty measures rather than the intrinsic frailty that somebody has, because frailty is very tied up to aging processes in my conceptualization of it. So we can't turn back the tide, but we can certainly do a lot to delay its onset, slow its progression. Those are the sort of things that we're really doing.
Right. Tanya Davidson has asked about the role of in-home aged care providers. What role do you see them playing in terms of the prevention and management of frailty? These are untapped workforce that we haven't really thought of before in terms of training and.
Yeah, absolutely. Do you want to take that, Tash? I'm hogging the question time a little bit.
No, it's all good. Look, I'm really hopeful that it is a good avenue, especially with the changes that are soon to come into effect, with the focus of in-home aged care and Aged Care Act looking at reablement and rehabilitation. I know that at the moment there's a lot of discussion around how viable this is with the actual processes that are becoming available, but not talking about that side of it. I think there's huge scope to implement some training and even some programs like we have going on at the moment that could supplement in-person rehabilitation or exercise programs.
Yeah, absolutely. I don't know if you wanted to unmute, Tanya, and add anything, but Certainly the way that the incentives are changing in terms of the home support at home program, and that there'll be no out-of-pocket, for example, for allied health and nursing, and much more out-of-pocket for things like gardening, and you would hope would shift people's focus towards that reablement, and that's the intent. But whether that kind of plays out as it should, I guess it's what we'll see happening.
And I just got a text from our team that attendees can't actually unmute. So
okay, rightio. So I'll stop asking people
the comments.
Rightio. So I think that's probably wrapped up the questions that are there. So if no one's got any further questions, we can probably just before we wrap up, I do want to actually thank Jess Barry, who's organised our seminars in ageing for the last, I think, 18 months, and has done a wonderful job, and is actually finishing up with us this month. So this will be her last month. So I hope everyone can join me in a virtual round of applause for Jess, who's done a fabulous job with this. And I know we've been getting increased numbers coming all the time to these seminars. And also, join me in thanking our presenters today, Professor Ruth Hubbard and Dr. Natasha Reid from the University of Queensland. And next month, Jess, yes, please say something.
I actually did that by accident.
Okay.
I raised my hand by accident, but yeah, thank you so much, everyone. I've really enjoyed hosting the seminars through their many iterations, and I will miss them. So, and thanks to Ruth and Natasha, because that was such an interesting presentation.
Thank you.
Thank you.
Thanks, Jess.
Thanks so much for having us.
Okay. So join me in thanking Ruth and Natasha. And next month, we're going to have Associate Professor Aileen Collier, who'll be presenting on older people, medication safety, and the role of the community pharmacist. So please join us next month. It'll be on Tuesday, the 15th of July. And thank you for attending today.
No problem.
Thank you, guys.